All righty. Next on the agenda, we have Dr. Aaron Sasson. Am I saying that right, Dr. Sasson? He is currently with Stony Brook University Hospital. They brought him in to run their neuroendocrine tumor efforts. Came from the University of Nebraska, where he did the same type of a thing with much success. Plenty of history and plenty of experience in treating neuroendocrine cancer patients. Please welcome Dr. Aaron Sasson.
Thank you, Bob, Marianne, and NCAN for the opportunity to come here today and to present. As was mentioned, I'm new to Stony Brook, but I grew up in New Jersey, so I'm new to the area. I mean, I'm familiar with the area, but I'm new to Long Island, so it's a pleasure to be here. Today I'm going to talk about pancreatic neuroendocrine tumors, another form of the neuroendocrine family. You heard a lot today, people talking about the midgut or the carcinoid. We'll talk about a little bit about the pancreas. And so I always like to show this or to explain to people where the pancreas is located and what's so special or challenging about the pancreas. You can see here, this is a picture. You can see the stomach, the intestines. And nestled in this groove of the intestines is the beginning portion of the pancreas as it extends across the body out over towards the spleen. It occupies a space in the back, so it's relatively inaccessible or difficult to access, I should say. And it's quite long in its anatomy, which we'll discuss a little bit later as to the significance of that. In terms of the GI tract, we will call this area, a high rent district. There's a lot of important structures in the region that I'll elaborate later as to why that's the case. Second point, what does the pancreas do? Well, the pancreas has two important functions. One, it helps with digestion. And it has what we call an exocrine function and an endocrine function. The exocrine function helps with the producing of the enzymes that help digest all our wonderful lunch we just had. Then we have an endocrine function, produces hormones, which also aid in the digestion process in terms of glucose metabolism, and well as fat digestion and fat production. It's important because this organ has these two different functions, and as such, you can have malignancies arise from either the exocrine portion of the pancreas or the endocrine portion of the pancreas. And it's important because the majority of patients, when you tell them that they have a form of pancreatic cancer, they always immediately assume that they have pancreatic adenocarcinoma, which is the exocrine portion of the pancreas. And only a small minority, probably maybe 5%, I exaggerate a little bit in this picture so I could get the words in there properly, will be of the endocrine origin. So the overwhelming majority of patients who have a neoplasm or a malignancy of the pancreas is from the exocrine. Only a small minority are going to be of the endocrine function, and we're going to focus on the endocrine portion. Furthermore, we can then subdivide those endocrine tumors into those tumors that have some hormonal manifestation and those that do not have any significant hormonal manifestation. And you can see the majority are going to be those that don't produce any hormones. The big difference is as follows. This red line is the survival curve for patients who have pancreatic adenocarcinoma. You can see it's quite steep. It's extremely steep. The blue line, or the purple line, is that for endocrine neoplasms. I can't tell you, and it does happen, patients come to see me, they're diagnosed with pancreatic adenocarcinoma, we have a pathologist review it, and they say, no, we think it's endocrine, how things change drastically with their future and in their outlook. So it's very important that we distinguish between the two. You've seen this slide or parts of this slide in previous talks. I won't spend too much time, but just to reiterate the fact that we are seeing more neuroendocrine tumors. And then on the small graph over here, you can see, or you can at least determine which ones we're seeing more of. And the black line is the pancreatic neuroendocrine tumors. Not as much as we're seeing for the others, but we're still all seeing an increase in the number of pancreatic neuroendocrine tumors, and I'll go and explain a little bit about that as well, moving forward. I get asked this question every time I see a patient who I diagnose a pancreatic neuroendocrine tumor. They want to know, is my tumor benign or malignant? And I spend a lot of time with patients discussing this concept. It's not black or white, it's very difficult to be black or white for pancreatic neuroendocrine tumors as to whether they are benign or malignant. And it's important to note that it's not necessarily a discrete value. So it could be, and as you can see by the next slide, I like to show them or tell them that it's a spectrum. You can have things that are more likely to behave in a benign fashion and things more likely to behave in a malignant fashion, and your tumor could be anywhere along that spectrum. Still a difficult concept because patients want to be discrete or to have it black and white, but I think this is a very important and probably the things I spend most talking to patients about. Following that, other things that can help us predict the behavior or the biology of the tumors are as follows. You've heard a lot about this, and I think it is an important point to reemphasize. The differentiation or the character and grade of the tumor are critical. You've heard some talk earlier today about the Ki-67 as well as the mitotic count, and it helps us differentiate between tumors that are what we would consider to be well differentiated versus those that are poorly differentiated. No more important difference. If your pathology report does not have this kind of information on it, you need a new pathology report. You need to have this information. This is critical in determining what we're going to do for you, what your options are. As you had heard previously by the former speakers, if you have high-grade tumor, you are treated very differently, and I will not be discussing the high-grade tumors in this part of the going forward of the discussion, only the well-differentiated tumors. Another factor which is unique or a little bit unique to pancreatic neuroendocrine tumors is that the risk of malignancy increases with the increasing size of the primary tumor. The larger the tumor, the greater the risk of it being of having a malignancy or potential to become a potential for malignancy. So unlike some of the other tumors you heard where you can have very small 5-millimeter tumors, for pancreatic neuroendocrine tumors, although you can still have malignant small tumors, the risk is extremely low, increases with size. So you can see not a very easy discussion to have with patients and their families with regards to whether their tumor is benign or malignant. And you'll see why this will come up going forward. Okay. Now we're going to talk about specifically for the non-functional and for the functional tumors. Now, non-functional tumors somewhat may be a misnomer, and for the most part, it's based upon what kind of syndrome of symptoms you have. For example, some of the hormones that the pancreas makes include insulin. So if your tumor makes too much insulin, we are very creative. We call it an insulinoma. If you make too much gastrin, another form of a pancreatic hormone, we call it a gastrinoma. And you can see you can have a glucagonoma. You can even have a tumor that makes too much somatostatin, one of the drugs we heard earlier, and we call that a somatostatinoma. Not very creative, but extremely easy to remember. And these different hormones, they result in particular or peculiar syndromes that a fair number of doctors who do not treat these diseases often will have never ever encountered. So patients always come to me and they say, well, how many insulinomas have you seen? Or how many gastrinomas have you seen? Well, in general, they are rare. Insulinoma is about 1 in a million, but seen dozens of insulinomas, seen dozens of gastrinomas. So if you have a specialty in it, you will see more of these tumors. But they have particular symptoms, And the delay in diagnosing a particular insulinoma or gastrinoma is in the order of anywhere from 3 to 8 years of symptoms before you're properly diagnosed. For insulinoma, almost a third of them are diagnosed unnecessarily with a psychiatric disorder because they have symptoms of constant hypoglycemia. And you can see there are other rarer tumors, such as VIPomas, which secrete too much VIP hormone, and ACTH, all they secrete different hormones. With regards to the functional tumors, almost all of them have a strong malignant potential so that they can spread to other organs, with one exception, and that is the insulinoma. They are invariably, almost always, benign, and their potential, only about 10% of them are really ever malignant. So they are the one of the pancreatic neuroendocrine tumors that are least likely to spread. Now, with regards to the non-functional tumors, you can see I have a number there showing 20 to 90% could be non-functional. In my practice, it's probably about 85%, although I've seen papers suggesting that it may be even a third are non-functional. I think that number woefully underestimates the number of non-functional tumors. Now, these non-functional tumors may still produce a hormone, but it may be a hormone that does not result in any clinical syndrome, or it may not cause any symptoms, but they can still produce a hormone. Or they may produce a hormone such as a pancreatic polypeptide, which doesn't have any clinical manifestations, in which case you have no particular outward symptoms of such a hormone. Or they could produce a hormone in a low volume, or a hormone that's inert, that's not biochemically active. So there are still some hormones, but suffice to say that there is no clinical manifestation. You don't get a carcinoid type syndrome where you have some clinical discrete symptoms that correlate with the hormones for the non-functional. The difficulty for the non-functional tumors is, how are we going to find them? I told you before, you have a whole set of symptoms that are resulting from too much insulin or too much gastrin. But for the non-functional, you have no hormone secretion. So you have very few specific symptoms. They are invariably related to the development of symptoms from a local effect on the pancreas. And I'll get to that a little bit later. There's no detectable level of peptides, although your chromogranin A level does correlate, and you can use that as a marker, but not typically used for screening purposes. And the most important thing is that the symptoms are associated with a tumor size causing obstruction of the pancreas, either of the duct, of the bile duct, or causing pain. You can see, with the exception of jaundice, having abdominal pain, having some weight loss, nausea, vomiting, or even diabetes could be relatively nonspecific and do not necessarily point to a picture of a problem with your pancreas. So a lot of patients present with late disease as a result of their symptoms not being specific. Very, very common to all the sorts of neuroendocrine tumors. The one difference is now incidental. It is very difficult now to walk into an emergency room, see a doctor, and not have a CAT scan. I almost think they should put it in as you walk out of the ambulance. They just put you right to the CAT scan, because almost you get one no matter what. And so people get CAT scans for looking for pulmonary embolism, or looking for kidney stones, or looking for appendicitis, and they find something by accident. So we call these incidental findings, things that are found by accident. And now I probably say this constitutes about maybe 25% of my practice. About every week I get 2 or 3 phone calls of something that was found by accident. They were looking for something else. When they're not found by accident, non-functional neuroendocrine tumors typically present at a later stage. They typically have metastatic disease. They typically have nodal disease. So more advanced issues. Here is a blow-up picture of the pancreas. And this is a high rent district. This is a very important area. Lots of very large, important blood vessels. Some of these blood vessels were shown earlier on some of the photos on the nice talk presented by Dr. Wang. And so here are some very important vein, very important artery, and here is the pancreas. We call this part of the pancreas the head of the pancreas, and we call this part the body and tail. And we typically use this blood vessel, the vein, right below it, as the dividing line. And that dividing line is important to us surgically because that's how we would go ahead and devise different surgical options for different tumors depending on where they're located in the pancreas. So you can see not one size fits all, and I'll show you differently what I mean by that. Depending on the location of the lesion in the pancreas would then determine what kind of operation you would have. People always ask, how did I get this cancer? What are the risk factors for pancreatic neuroendocrine tumors? As you can see here, the increase as we age, the increase of developing a pancreatic neuroendocrine tumor increases. Unless someone here knows something I don't know about age and reversing it, nothing we can do about this. But if you do, please see me afterwards. I'm interested in being younger myself. But age is a risk factor. Now, suffice it to say that there are some inherited genetic diseases or syndromes that are associated with pancreatic neuroendocrine tumors. You have MEN1, with almost about maybe 80 to 100% of patients will develop a pancreatic neuroendocrine tumor. And then you have some rarer or less common diseases or syndromes. Von Hippel-Lindau have about a 10 to 17% chance of having a pancreatic neuroendocrine tumor, as well as other pancreatic pathology, not just the neuroendocrine tumors. You can get pancreatic cysts in there as well. In von Recklinghausen, which is also known as neurofibromatosis 1, you get a very unusual somatostatinoma of the ampulla in the duodenum, and tuberous sclerosis, about a 1% chance of having pancreatic neuroendocrine tumors. I formerly had a clinic where we would see all these patients. And so we would have to screen and look for these tumors for these patients. And particularly for the VHL and the neurofibromatosis, these are very common. I'm surprised we see a fair number of patients who have these inherited syndromes. You heard a lot about a team before. And what I failed to mention, and I apologize, and it's a very common theme that I'll repeat as well. Probably the two most important members of your team that you will never meet is going to be your pathologist and your radiologist. And the radiologist is going to be probably two different kinds of radiologists. Remember, radiology is relatively specific. We're talking about the cross-sectional imaging, and we're going to talk about nuclear medicine radiologist. You'll hear a little bit later about interventional radiologists as a therapy, but those are doctors that you will meet, but you probably will never meet your nuclear medicine doctor or the doctor reading your MRI or CAT scan. So one of the things that we look for on how do we develop or how do we look at for pancreatic tumors, there's a specific technique called endoscopic ultrasound. We put a flexible tube down your throat, little ultrasound probe, and we can take a look at your pancreas in very fine detail. However, an ultrasound is kind of like a Rorschach test. You know, it's not very reproducible. You're taking a still picture of a movie, so it's not something that you can easily transport and say, what do you think of my endoscopic ultrasound? You actually have to be there for the whole entire procedure looking at it because it's a moving part. So it's not very, it requires expertise to do and to evaluate. A lot of patients come to me, they come to me with a CAT scan and an MRI, and they say, I have had these tests. What do you think? And I tell them, I look at them and I say, oh, these are good CAT scans, but they're not great CAT scans. And everyone wants to know what makes a great CAT scan or a great MRI. Well, it's very important because scans done for neuroendocrine tumors have to be done in a specific manner, whether that be for midgut tumors or pancreatic tumors. They have to be done in a specific fashion. And so your radiologists have to be adept at doing them and B, at interpreting them. So very, very important. So I'm often repeating scans because they were not done to the specifications that would be required for a neuroendocrine patient. So very, very important. Obviously, a lot going on with nuclear medicine for both PET scan as well as a somatostatin receptor scintigraphy, and both with the triotide scan as well as the new gallium scan. Here is a picture of a patient who, this is a mid-gut tumor, and you can see on the very, maybe you can't, I apologize if you can't, but there's a tumor. You can see the tumor bulk in the mesentery on the triotide scan. He was being seen, and this is a gallium scan done at our institution just recently, showing all the tumor deposits that were missed on the triotide scan. So you've heard a lot of people talking about the gallium scan. It's probably going to be a game changer with regards to the management and evaluation of patients with neuroendocrine tumors. And you can see all these spots on the depicting liver lesions that the triotide scan did not show on the side over here. Here's a PET scan. And then here is, this is an triotide scan done about a year ago prior to us getting the gallium scan, showing 2 liver lesions that the PET scan did not show. It is important. Patients always come to me and they say, well, what's my best test I'm going to have? What's the best scan to have? And I tell them that these are all complementary. We're not going to have, you know, a high quality MRI is useful in the setting of a well done gallium scan or a well done triotide scan. Sometimes, so it's not just one scan that you may need. You may need a multiple scans, but they have to be done properly and correctly and with expert interpretation. So it's amazing how much of the patient's treatment depends upon accurate pathology and accurate radiology. 2 doctors who many patients never meet but play a vital role in their team. Lastly, when it comes to talking about patients and staging, you got to listen to the patient. And this is a point I emphasize to my trainees and to other health professionals. At the risk of dating myself, 15 years ago, I just started my first job, and my first patient comes to me. She has a history of having a glucagonoma, so a tumor of the pancreas that produced too much glucagon. She had removed about 20 years prior. So she was, I think, in her 40s when she had it removed, and she's now seeing me when she's 60. She comes to me and she says, my tumor is back. I'm a young doctor. I'm all excited all about glucanomas. I had a whole bunch of them in fellowship. I'm ready to go see her. And I said, let me see your CAT scan or your MRI. And she's like, what CAT scan? What MRI? I don't have a CAT scan or MRI. And I said, well, then how do you know your tumor's back? And she said, look at my belly. Like, okay. Her tumor was back. This is the typical rash she would get from glucagonoma. She knew it came back when she saw the rash, and then she saw her doctor. Or she came to see her doctor. Her doctor then sent her to me, and we then we then got the CAT scan after. So always listen to your patients. You will have stories like this, as well as many of you do, and Dr. Wang, who also presented with the patient who had the neuroendocrine tumor involving the testicle. So this is vitally important. We went on and resected her liver disease, and her rash went away. With regards to staging, why we go through the process of staging for pancreatic neuroendocrine tumors? Because I need to know, and we need to know to make the best possible plan, is your disease localized to the pancreas? Is it gone outside of the pancreas? And has it gone to other organs? It helps us prepare a plan for us, and it helps inform you because it helps give you very important prognostic information. You can see this, the survival curve are in green here for neuroendocrine tumors that are localized, that have not spread beyond elsewhere. Those that have gone through lymph nodes, and as you can see, as it goes through the other organs, less. So it helps give prognostic information, as well as helps develop a plan of attack for the for patients for your team. I'll briefly talk about the surgical options with regards to the pancreas tumors. And I'll try not to give any trade secrets, but this is not meant to be a DIY. I don't want anyone going home and trying these without proper supervision, because they are quite complicated. So this is, if your tumor, I'm gonna keep a picture of the pancreas here to show you. If your tumor is in the head of the pancreas, one of the options is going to be a Whipple operation. A Whipple operation can be done a couple different ways, but it involves removing this portion of the pancreas. You can see here, this portion of the pancreas, this portion of the intestines, and the bile duct. And most patients turn to me and say, "Are you kidding me? I have a tumor maybe the size of a gumball, 2 centimeters, and you want to do all of this surgery. You want to remove my bile duct and my intestines, all to remove a gumball-sized tumor in my pancreas?" The reason being is that the blood supply to the intestine and to the bile duct and to the pancreas in this region is all one. And it is very challenging or impossible at times to remove just that portion of the pancreas or the intestines without violating or interrupting the blood supply to that part of the organ. So you do have to remove all of it together. Furthermore, we always want to know about lymph nodes because this cancer can spread to lymph nodes and often does. All the lymph nodes live in this area. And so if you remove the whole thing together, you can get all the lymph nodes. So one of the reasons why we would do a Whipple operation, about anywhere from 4 to 6 hours, depending on certain factors. And it does have a associated risk of complications afterwards that can be quite challenging at times. Pancreatic neuroendocrine tumors is like real estate. It's all about location. If your tumor is in the body and tail of the pancreas, then we remove this portion of the pancreas, typically along with the spleen. Some patients say, "Well, why are you removing my spleen? It has nothing to do with my pancreas. The tumor's not involving it. Why are you taking out the spleen too?" Well, at times we have to, and at times we don't, and I'll show you another picture when we don't. The blood supply you can see the blood supply to the spleen is right behind the pancreas. And sometimes it can be very challenging or difficult to separate the pancreas from the spleen, from the blood vessels to the spleen, so you have to take them both together. Furthermore, all the lymph nodes live around here, and if you wanted to try to get as many lymph nodes, you would invariably have to remove the spleen as well. Now, in some patients whose tumors may be small, we may not need to remove the spleen, and that could be done and depicted here, where we are taking the pancreas, and then we are painstakingly detaching the pancreas from the spleen. It is very difficult to talk about surgery after lunch. I tried very hard not to show any intraoperative photos. I didn't want anyone's getting any GI upset by me showing some intraoperative photos, but I apologize. But this can be done, and sometimes this can even be done laparoscopically. Now, in some patients, just removing the tumor itself is all that's required, particularly for the insulinoma. And here's a picture. This is what a normal pancreas looks like, this pink tissue right here. And then this is what the neuroendocrine tumor looks like. And here we are, we've just carved it out. This is showing it in the body. This was actually, this tumor was right here on the surface, and we just carved out this tumor. And you can say, well, how can we do that? How can we just carve out the tumor? Here's a picture of the tumor. And what may be difficult to appreciate is that there is a lining of thick tissue around this tumor, kind of like a little capsule. So a lot of these tumors have a capsule around them, so they don't have extensive amount of these tentacles or feelers that go outside of the pancreas as other cancers do. So at times you can excise just this. Now there's pros and cons to doing this. The pros are it could be easy. This is done laparoscopically. The cons are that we don't always get any other lymph nodes. So if you have a tumor that may be going to the lymph nodes, this could be considered inadequate. But it can be done laparoscopically, and it can be done safely, and it's typically done most commonly for insulinomas, or I use it for very small other pancreatic tumors that are found by accident, which I'll get into a little bit later. In some patients, This is a MRI showing two tumors here. And I couldn't get all the MRI, I couldn't get the whole scan, but this person had 15 tumors in their pancreas and a large one in the head of the pancreas, and we had to remove out the entire pancreas. This is typically most common for those who have MEN1 syndrome for having them. Although even for the MEN1 syndrome patients, we try to save some pancreas, and we can get away with sometimes just removing most of it, leaving a little bit. But this person had a tumor in the head of the pancreas as well, a large one, and so we had to remove the entire pancreas. We can even get creative. Here's the part where we just take out just the middle portion of the pancreas for a tumor located here. Done very rarely, but it can be done. We want to try to save pancreas function, minimize risk of diabetes and other complications. Okay, that's how we talk about the pancreas. In about 50% of patients, over 50% of patients with pancreatic neuroendocrine tumors will get liver metastases at some point in time. So here's a patient who had a pancreatic neuroendocrine tumor that I removed 3 years prior. She then left the state, moved elsewhere. We told her what to do for her follow-up. Didn't do the follow-up. Had some pain. Got a CT scan and then flew back to Nebraska to move again to be closer to family. And so you can see here, this is a normal liver, and this is these black spots are tumor. There's actually a small tumor over here. So how are we going to approach this patient? Well, there's many options we can have for treating liver for tumor in the liver. You heard about chemotherapy, you've heard about targeted therapy, you heard about peptide receptor therapy, you heard about biologic therapy. You're going to hear soon about interventional techniques for managing this. But we can do a combination of surgery or ablation for this. And in this person, we were able to remove 95% of the tumor just by taking out this part of the liver. The whole right lobe of the liver was involved, and then we just carved out some of these smaller ones, or we burned them with either heat or microwave now. And we can do that to improve survival. I think if you can debulk these patients, they will go on and live longer, and you can go ahead and improve their quality of life. I recall one particular patient who had a VIP-oma, and there is probably no other dreaded disease than having a VIP-oma. She was in the bathroom 20 times a day. 20 times a day. She couldn't go anywhere. We debulked her tumor, got out about 85% of her tumor, and she was then down to two bathrooms twice a day. Ultimately, 5 years later, the tumor did recur and it got worse, but by that time she was already in her late 80s. But for those years when she had very few symptoms after we debulked her VIP-oma, I thought she was, if she had any more children, she would name them after me. I mean, I was her hero and her family's hero, because now not only did she get to enjoy life, but her family got to enjoy her. Her grandkids got to see her, because otherwise she couldn't go anywhere, because she lived at home. It's not even like living from bathroom to bathroom. She wouldn't go anywhere. Even in the visit, we had to stop the visit sometimes because she would have to go in between prior to the liver surgery. So improving quality of life is extremely important as well. And we know that removing liver tumor does help. At least there's some marginal data, quality data, to suggest that. You can see in multiple studies that if you removed a tumor or ablated tumor, you can improve the survival as to those patients who did not get surgery. That's somewhat, though, counterintuitive, because there are some patients who are technically not possible to have a liver surgery. You would think of them as having more disease than others, which means that they have more advanced disease. Another unique problem that comes up often, unfortunately, is this patient. This is a large tumor in the pancreas. This is a liver with over 100, maybe 200 liver lesions. what are we going to do for this patient? What needs to be done about their primary tumor? So we studied this. We studied this at Nebraska, and we decided we were going to group patients of all of our neuroendocrine patients, but non-functional, that is, to those that did not have any liver lesions, those that had liver lesions occupying less than half of their liver, and those that had more than half of the liver occupied. Arbitrarily numbers. Other studies have used a third, 2/3, others use 3/4. It's arbitrary. And you can see the survival, but if you had a lot of tumor in your liver, wasn't as good as if you had half or none. So that helped us formulate a plan. So for patients like this, who have more than half of their liver, taking care of their primary tumor is not an issue. Their factor predicting their life expectancy is all about the liver. As a matter of fact, for the majority of patients with pancreatic neuroendocrine tumor, unless you have a hormonally functional tumor, it's all about the liver. Here's some other data showing the same thing. Whether you have tumor involvement of the liver greater than 50% or less. Another study showing the same thing. As I mentioned, we started seeing patients who were just found by accident. And you would think, okay, being found by accident is going to be better than being found by symptoms. In general, yes, but unfortunately, still even a quarter of the people who were found by accident had liver metastases already. So, and 10% already had obvious lymph nodes on imaging studies as well. So even though they did better, they were better than those that just came in with symptoms. Still, we have to do better. Even being found by accident was not great. It does lead to smaller tumors, but still a fair number of patients still had metastatic disease. This shows the increasing number of pancreatic neuroendocrine tumors from 1998 to 2001. A significant threefold increase in the number of tumors identified nationally. What's also notable is that the number of tumors that are less than 2 centimeters, which was about, I think, 7% in 1998, was now 20% in 2011. And at least in our experience, is probably increasing in size. Now comes, what do we do about these tumors? Well, we know that if you remember, as opposed to the midgut tumors, size of the primary tumor is very important. So we know that if you're over 2 centimeters, you should probably have it removed. If you're less than 1 centimeter, unless it's, I'm sorry, this is all for non-functional. There is all functional tumors should be removed. If your tumor is non-functional and less than 1 centimeter, you can probably get away with observation. Then the controversy comes, and what do you do between the 1 and the 2 centimeters? And I'd say that that's probably very tailored to the individual. A 80-year-old gentleman who has severe heart disease and has angina, we're not likely to take him to the operating room. But a 30-year-old found by accident, we most certainly are. So to summarize very quickly, neuroendocrine tumors are in general uncommon, but for a lot of the doctors who are speaking here today, this is all their practice. These tumors typically would occupy, my former practice was about a quarter of my practice was neuroendocrine tumors. They are increasing. We're going to see more of these. We're going to see more of these even by accident. They behave differently than pancreatic adenocarcinoma. Very, very important. And even pancreatic adenocarcinoma requires an expert team. Pancreatic neuroendocrine tumor requires even a more diligent expert team than it does for adenocarcinoma. And surgery remains the primary treatment that we're going to try to improve survival at this juncture, regardless of the intent, whether it's even debulking to help with symptoms or to go ahead and to improve survival. Surgery is one of the mainstays of treatment. And I'll hold off any questions until after the summary, after the summary. With that, thank you very much.